So hi everyone, good morning. Welcome to IWC webinar. We are very happy to have you today. So thank you so much for joining. We really appreciate your time, participation as usual. Our webinar is meant to be an interactive and dynamic webinar. You will see today, for example, new things, a few quizzes during the session. So we invite you to take part and share your answers. We also have Q&A questions today. Lucian will manage the Q&A and we will do our best to answer as many questions as possible within the time we have. So at the end of the webinar today, you will receive all the quiz questions and the answer by email. I would like, of course, to thank Lucian, Gustavo for their support in organizing and running this symposium since the first meeting. Thank you, Gustavo and Lucian. And of course, for today, our colleagues from Singapore and Colombia, Venezuela, the first participation of Colombia, Venezuela, for preparing the two great clinical cases for us today. Thank you, Fabio, Angel, Wang, and Ze, of course. So we have about 1 hour for two cases, the debates and the discussion, and I will handle it over to Gustavo right now. He will guide us through the cases, Lucian for the Q&A, and I wish you all a great webinar. Thank you. Enjoy.
Thank you very much, Alam. So I'm very happy to be here. Welcome, everybody. It's great to have you all here. We look forward to sharing ideas, learning from each other, and enjoying a great session together. So let's start it. The first case is will be presented by Wang Qiao from the Singapore General Hospital about Kienbock disease. Wang, if you can share
I'm going
your
to share my
screen
screen
and start the case. Thank you very much.
Okay, is it showing on everybody's screen?
Perfect.
Yes.
Okay,
Great.
so thank you very much. I'm going to present this case from Singapore General Hospital. The consultant in charge is Dr. Chung Ziring. So, okay, so start with the history. This is a 56 years old female who is a right-handed nurse with a past medical history listed below. The most significant one are the seronegative rheumatoid arthritis and the asthma. So when he presented to us, he already have a long history of right wrist pain, which she has bear with it for a few years. However, it has been exacerbated because she carry a heavy oxygen tank with the right hand. Since that, the pain has become worse and persistent for a month. That's why she come to seek for our help. And previously, she described the pain was more like an on and off aching kind of pain and not really affecting his daily activities and work. But now apparently it is worse. She also has this background of rheumatoid arthritis, which she's been treated with low dose of steroid. This is the physical examination on her first visit to us. Shows there's no significant swelling. The pain is mostly around the dorsal SL region. There is some limitation of the wrist range of motion, and the right hand, which is a dominant hand, shows slightly lower grip strength compared to the left hand. And oh yes, so
okay, here we have the first question. Here we have the first question about the classification. So we want that the audience answer this question, and while the audience is answering this question, I want to ask Mohammed Al Hassan, how are you doing? Could you please tell us
thank you.
What do you see in the images and the Leachman stage that you think is in this patient?
I think this Littman stage 3B, there is a reduction of the carpal height, visible instability of the proximal row, the carpal bones, cystic changes. All these give us a feature of instability, and the lunate decrease in the size in the lateral view. So I am with stage 3B.
Okay, great. Thank you.
Gustavo, sorry, I would like
Yes.
to ask the audience. There are many questions. We have 6 questions for this case, so you can answer one question after the other. You can when you have the answer. Thank you.
Thank you, Lam.
I have a question for everybody. Do you think that those fragments that we see volarly and a little bit dorsally are signs of the lunate or maybe osteoarthritis? And does it change your point of view? I don't know. Lorenzo, you have a lot of experience with Kienbock, so what do you think?
I think I'd probably ask something else than X-ray, but at this stage, for me, it's a fragmented lunate probably, and probably what we see volarly are fragments of lunate partially dislocated and after its fragmentation. So probably that would be at least a 3C because of the fragmentation, and the scaphoid being already a little bit flexed and collapsed. So yeah.
I agree.
Can you move Wang to the MRI?
Yes. So here are the sections of MR images.
Great. Here we have more information. Can you explain these images for us?
Okay, so here are the MR images, which basically showing, first of all, there is arthritic changes. There is a thinning of the cartilage. The joint space of radiocarpal joint is reduced, and the lunate at the focus of the images, lunate is deformed, it's ischemic, and it's, if you can see from here, there is fragments, so it's fragmented. And for the scaphoid, you can see it's very flexed. You can see it's very flexed. And also there is couple swellings of the capitate, of the tracheotomy. Yeah, basically that's the most significant findings here. And there is also some TFCC injuries, which is not very well captured on these images.
I want to ask to some of you if somebody prefer the CT scan instead of the MRI, because sometimes it gives more information about the structure and the position of the bone. Did somebody prefer the CT scan?
I can tell you,
Francesca?
Gustavo, that
Yes.
I always ask also a CT scan. No, normally the patients come with an MRI because they think somebody told them that you have a Kienbock.
Yes.
But for me, asking a CT scan is mandatory. I don't know what you think about it, but for me, for the logics of the treatment, for planning the best treatment for them, because there is so many types of treatment that we can give them, it's very important to me to see also the CT scan. It gives you the small details that sometimes the MRI doesn't give you, but it's my own opinion. I don't know if you have the same.
I agree
in my
with
opinion,
Lucian.
but let's hear Francesca first.
I think the MRI is more useful in early stages when maybe in a stage 1, but then in advanced stages you need to see arthrosis, like you need to see how is the cartilage, and I think this is better provided by a CT scan.
Maybe we can ask. Maybe we can ask Zhe or Wang if they ask for a CT scan, what is their opinion? Because
Say, how are you doing?
Yeah, so
Hello,
yeah,
Zay.
hi. Yes, I did not ask for a CT scan in this case. MRI to me is MRI actually, I prefer MRI a lot. But of course I might change my mind after this webinar. I know that CT scan gives us a very good picture in terms of the fragmentation of the lunate bone and perhaps cartilage, whether if there's any bad degeneration and so on. But to me, MRI, with some contrast, it does show us whether if the lunate bone is ischemic or if it's still vascularized. Of course, we all know that arthroscopic is always the gold standard, but it gives me a rough idea. It also tells me quite well whether the cartilage is also good as well, if there's chondral thinning and so on. In this case, you can see that the lunocapitate joint, there's obvious thinning of the cartilage. There's obviously reduced joint space. And I got quite a lot of information from the MRI itself. And also MRI is quite good for me, in my opinion, with soft tissue, especially ligamentous TFCC, if there's any other associated, because actually this patient has pretty much generalized pain over the midpoint of the wrist. She also has some pain over the ulnar-sided wrist pain, and also with the background of rheumatoid arthritis, it really just mixes everything up. So it also gives me the idea of how bad the synovitis is as well of the wrist. So in this case, I did not ask for a CT scan. MRI, in a way, gave me quite sufficient information.
I think the question is, I agree with Zay. The MRI gives us most of the information. And the question is, if we need to have some subtle information about the bone architecture, should we add a CT scan to the MRI? It depends on, I don't know if anyone has an opinion here. Usually I ask for an MRI and a CT scan to have a good view of the shape of the bone, if there is any doubt on the MRI. I don't know if someone has an opinion about this.
Yeah, the same for me.
The thing is, Lorenzo.
Go on, Gustavo. Yeah.
No, please. I want to hear
No,
you.
I was just saying the same thing. I think for me, MRI is sufficient only in early cases when you know the shape is preserved on the X-ray and in MRI. Then probably in that case, the CT scan does not give you much more information. But as soon as I have a doubt on the shape or the fragmentation on the lunate, then I ask a CT scan in addition to the MRI. Yeah.
Well, I totally agree with Lorenzo. You know, of course, we are just discussing, and is the same. If you want to order an MRI or a CT scan, I totally agree with Lorenzo and Francesca that perhaps MRI is very useful in early stages. And for me, I usually use the MRI to achieve the diagnosis, but perhaps to decide the kind of surgery that I can do or I need to do in the future, I use the CT scan. I want to hear another school from Spain. I don't know if Victor Triviño and Lorenzo Pintado are here. If you can share with us your algorithm to study these patients.
We see Alfonso, we see Victor, and there is hello, Alfonso. Don't hide.
Alfonso.
Can I say?
How are you doing, Alfonso?
Can I say just a comment?
Thanks so much. How are you?
Very good, and you?
Fine, thanks.
What do you do, Alfonso? Do you order a CT scan or an MRI when you want to do a surgery in this patient? How do you decide the kind of surgery or the technique are you going to use?
I couldn't see the case because I already joined in the last 30 seconds. So
don't worry, it's a Kienbock disease.
Okay.
So in this case, we have perhaps stage 3, and we want to decide the technique for surgery. So in this case, you order a CT scan or an MRI, or both of them, perhaps.
How old is he or she? Where is he work for?
Wang, can you remember us the age of the patient?
Yeah, patient is 56 years old, female.
56, female.
Okay, 56. And how did she work for?
Oh, she's a nurse.
Nurse?
Yes, and this is her dominant hand.
Okay, so
And
do
she
you have
also
the
have a
X-rays?
background of rheumatoid arthritis.
Can you go back one slide
Yes.
to show the X-ray to Alfonso?
Okay, sure.
Alfonso, the
Okay.
question is in Madrid, because we were debating on should we ask for an MRI or a CT scan? And the question is, there is a debate here. The question is, what do you do in Madrid with Pedro?
Okay,
In this
so
case, MRI, CT scan, or both exam? What
yeah,
do you prefer there?
probably I would go for a CT scan to see if the lunate is fragmented or not, because I know I can see in the X-rays properly that the joint is not going well. So probably the CT scan gives me more information about the lunate bone and the position of all the bones in here, because I can see the scaphoid is flexed, and also the VC deformity. So I would go for a CT scan probably.
Thank you.
Okay, thank you very much, Alfonso. Francesca, did you raise your hand?
Yeah, I had a small comment because
Yes.
of course also there is a problem with the quality of MRI. Not everybody has the same machine. And also, I don't know how you do it in other countries, but in Spain, sometimes it happens that the patient moves during the examination, and so that the quality of the image is not good. So this is why I think CT scan is also better.
Yeah, it's a good point.
Okay, thank you very much to both of you. So now, I'm sure that MRI was enough to anyway to see what we need to do in this case. Wang, can you go on with the case and you
Yes.
can show us what did you do?
So, okay, should I minimize this thing or just leave it somewhere here? The quiz? Okay,
Well,
I just put it here. So, yeah. So we start some conservative treatment. Then she had a second visit with us. At this moment of time, she has tenderness around the SL region, the mid dorsal wrist, even the ulnar side of the wrist. The scaphoid tubercle at this time is not tender. Then, based on her symptoms and MRI, she was offered a few options for surgical treatment. So all these 4 choices have been discussed with the patient.
Yes. I just want to ask the attendees to really answer the quiz about the different treatment option, please.
Okay, so we have offered the patient 4 options. First is relative more conservative. It's just to do neurectomy for the PAN and AN is just for the pain, but has nothing to do with the joint and the structure. Then another choice we offer is for a proximal corpectomy and the use some form of dermal allograft for the carpal space just to maintain the space. Then another choice is the lunarrectomy with scaphoid capitate fusion. This will not alter the carpal structure too much, and the patient will remain some motion and strength. Then the other one is total wrist arthrodesis, which is quite definite for the pain treatment, but patient will obviously lose all the range of motion for the wrist. So eventually, patient choose to do the scaphoidectomy and the SC fusion. Should I continue with the video or we should ask the panelist?
Well, we can discuss a little bit.
Yeah, I want, Mustafa, excuse me, I want only to share a comment of a great expert and friend, Ali Kavit from Turkey. So he also thinks that you should do routinely MRI and CT scan for Kienbock disease to have a more detailed picture and enable a better planning of surgery. Okay, so I wanted to share also his experience.
Thank
Thank you,
you.
Lucian.
Thank you, Ali.
Okay, so we can ask to Fabio, how are you doing?
I
How are
believe
you
in this.
doing? What do you think about this case? Which treatment option will you choose?
In this case, it's important. Obviously, in my case, I use more MRI than CT scan. Probably change the opinion now with this case, but I believe for me it's important the view with the scope, because I know more information about the quality of the cartilage of the midcarpal and radiocarpal joint, and after it decide what is the best option for this patient. Um, I have two cases with a lunate excision. I have the opportunity to visit Gustavo Gomez, but I know the evolution of these cases. But obviously, I need to know the quality of the cartilage. For me, is very important. Um, I don't know if proximal row carpectomy is good option, because in the MRI I saw the lunate faucet is a no good condition, but probably is more my decision is more near total Gris arthrodesis in this case. But for me, it's very important to know the quality of the cartilage, and I will use a scope and make a decision after it.
Yes.
Great. Thank you, Fabio.
We
Alejandro
should
Balsan,
not,
how are you doing?
sorry,
Yes.
just Gustavo. For the attendees, there was a question in the quiz. Besides the Lichtman classification, is there another system that allows a more precise staging of Kienbock disease? If yes, which one? I think we should not forget the arthroscopy, of course, not only for the Bain and Beck classification, we know. It is arthroscopic classification that allows us to have a more precise, an arthroscopic based classification, to have a more precise diagnosis, and also to see the cartilage. So I agree with Fabio. To really evaluate the cartilage, we should not forget the arthroscopy. You can go on, Gustavo, sorry.
Can I ask you all, what is your opinion about denervation? Okay, because I don't have a good experience with denervation, especially in this kind of diseases. I think that they are good for a small amount of time, and then they gain again the pain. And I have the same experience with slack and snack wrist. So I wanted to ask you, what is your experience with denervation?
Not good.
Alfonso.
Not good. Lorenzo, not good.
We see Alfonso
Alfonso,
wants
yes.
to speak.
I am very polite, raising my hand. Yeah, for me, I have the same feeling as Lucian commented before, because probably I think it's my hands, because there's a lot of techniques in denervation. Some people do ANI, PNI, also radial area. So there's like a lot of types of denervation. But in my hands, I have like 50-50. 50% of my patients do really, really well, and the other ones do really, really bad. There's like no point in the middle. So for me, it's like very disappointing. It's not the best technique, but in some particular cases, probably you give more time to the patient to think about other options.
I'm also raising my hand here.
Thank
Politely.
you, Alfonso. Alejandro.
Hey, hi everybody. Sorry
Hello,
that I was a
Alejandro.
bit late.
Hi.
I don't know if the mic you can hear well.
Yes.
Yeah, going to the past discussion, for me it's almost mandatory asking for a CT, but also the MRI to take part of the decisions. But doing the scope radiocarpal joint and really seeing the quality of the bone makes me take the last decision on what is a treatment that I'm going to do. I don't have too many cases of it, but I've done a partial lunectomy, and sometimes I just leave the dorsal and the volar wall of the lunate, and for me, it's been like quite enough, and maybe you don't have to burn any bridges, so you have another treatment if something fails or if it advances. So I don't know if Gustavo, that was a question that you were going to ask me, but that's basically the treatment that I do. I do the scope and then take the decisions once I'm inside the radiocarpal joint.
I was going to ask you exactly that, and if anybody do, I want to hear Lorenzo now that he's raising the hand. But does anybody do a first time arthroscopy to see the classification and to decide the treatment, and in a second time you go with the definitive treatment? Because for example, Fernando Correa used to do this. So I want to know if somebody do this and to hear Lorenzo first. Lorenzo?
Yeah, thank you. So to answer right now your question, as much as I can, I do it in one stage, so diagnostic arthroscopy, and most of the case, you already have your strategy in mind, and it just confirms you that you were taking most of the case. And if I really have a big surprise, then I can eventually propose the patient to change and defer the more different surgery, but usually in the same stage. What I wanted to say about the denervation, two things. First of all, doing a complete denervation of the wrist is not so light surgery. If you want to do it properly, you have to do radial, volar, dorsal, and creating a lot of scar tissue. So it's not that always a light surgery. And second of all, in that case, we have a Kienbock disease, which is an evolutive disease. And there is something in Kienbock disease that as long as you have a preserved or ratherly preserved radial column, then you can still do some satisfactory surgery. As soon as you have a collapsed or cartilage damage into your radial column, then you have to move on to much less interesting procedures for the patients. So denerving here, while you could still save the radial column, I don't think that's a good strategy. That's it.
Thank you. Alam?
Yes, I just agree with Lorenzo. As usual, the denervation at this stage doesn't stop the evolution of the disease. So a single denervation is not a useful option for me here. The second point, I agree also with Lorenzo. We cannot say to our patients, at least in France, we're going to do a first stage of arthroscopy, and after we will choose the therapeutic option. We need to put on the table the different therapeutic options and to act intraoperatively, to decide intraoperatively. We know we have most of the information preoperatively according to the MRI here. We know it will probably not be a conservative treatment, and we discuss the different options with the patient and we decide intraoperatively. That's what I wanted to say. Thank you.
Thank you. Say, please, I want to hear you.
Yes, so I completely agree with one stage. I don't believe in doing a wrist arthroscopy assessment and then you see everything and then you're like, okay, and then come back and then do a second stage. I think most of our patients may not want us to do that unless there's a very good discussion between us and the patient. So generally, personally, I find that MRI is sufficient for this case. It tells me already that the cartilage is damaged. It tells me that the joint space is narrowed. It tells me that the treatment is mainly a salvage treatment. You can't really salvage, you can't really save the lunate. That's my thinking. And especially this patient is already almost 60 years old. We had a very thorough discussion about this. I would say it's quite a difficult discussion because she so my thinking process is that, okay, you want to keep it simple, neurectomy. Personally, I've never done a pure neurectomy. I usually do it in conjunction with other procedures. So I don't know whether pure neurectomy works, but there have been papers that show that pretty good outcome. But I think hearing from all the panelists here, perhaps maybe it's good to just do it in conjunction rather than just pure, especially in this case. Proximal row carpectomy with dermal allograft, I think is quite a sound option for me. That's why I offered it, mainly because I was worried that the lunate facet has some cartilage loss. So we do a PRC dermal allograft that could save her some motion. But this patient does not want the PRC. So she does not want the bones to be removed. So that was the main issue. And the total risk arthrodesis is not really an option as well for her, mainly because she does not want any implant. So hence the decision for just a pure lunate excision and scaphocapitate. And that was my thinking process. But I would like just yes.
No, sorry. Go on. I thought you end.
Oh, okay. So I'd just like to know as well. I would just like to know as well, like, with the CT scan, let's just say if you know that there's one fragment or double fragment of the lunate bone, for example, how does it change in terms of the management in this case, though?
Ji, can I answer this?
Yes.
I think that it's not only about a matter of the fragments, okay, which is important to see in CT scan, but I think sometimes you see in the MRI bone edema and you think, okay, the capitate is ruined, okay, or the lunate fossate is ruined, but then in a CT scan you see a very good shape of the bone, and obviously it's you need to confirm it with an arthroscopy. I always do an arthroscopy, but sometimes the image in the MRI is in advanced stages are more catastrophic than you think, and the CT scan gives you a right dimension of the situation, and when you have fragmentation of the bone, it helps you also to plan your surgery. If you have only two fragments, some colleagues do a fixation of the lunate. It helps you also in this matter. So I don't think need to do an MRI. I think MRI is mandatory also, but I always want to see also a CT scan if it's possible. I also want to share again an experience of Ali Kavid from Turkey. He says that in his clinic, usually the treatment in these cases, which is very interesting, is a vascular medial femoral osteocondyle, okay? And in the last period, he started to do arthroscopic lunectomy with dorsal intercarpal ligament application, okay? So normally they treat this kind of patients with medial condyle, medial condyle flap. But he has a good experience lately, even if it's a short experience, with lunectomy associated with plication of the dorsal capsula. What do you think about it?
I just wanted to say something. I agree with Ali. I just agree also with Z. We need in this kind of cases to deal with the patient, because we have a young patient, a female. Maybe proximal row carpectomy is a very good option with interposition, capsular flap interposition or dermo allograft, but we need to deal with the patient. And many of the young patients don't agree with these severe options. So we can propose first simple option like single lunarectomy, and it doesn't burn the bridges for the proximal row carpectomy after. That's what most of the time we propose to the patient. Thank you.
Yes, see, I see that there is not the option lunarectomy alone. Do you do lunarectomy alone without the scaphocapitate fusion, or you always associate the scaphocapitate fusion with the lunarectomy?
Well, I don't have a lot of experience in Kienbocks, and it's very rare in my practice. So this is one of it. I did think about a pure lunate excision, but my thinking process is that this patient is also a rheumatoid patient, and I don't think the capsular, the secondary stabilizer is strong enough for just a lunate excision. And I'm afraid that the capitate will slowly still migrate proximally. But this is my thinking process, but feel free to share your thoughts. And I will still need to do some form of stabilization of the scaphoid capitate, to prevent any proximal migration of the capitate bone.
Yes, but now we have there is a tendency to add there is Lorenzo, you can confirm there are some studies with some series when we have a good follow-up for this patient up to 11 years for the single lunarectomy, and there is a tendency now, as Ali Khalid told us in the Q&A in the chat, sorry, to add a dorsal reinforcement, maybe a big dorsal reinforcement to avoid this kind of migration of instability after single lunarectomy. Lorenzo, if you...
Yeah, absolutely. It was actually one of the topic today at the meeting in New Zealand. It was, what do you do in this type of case? And actually now the tendency is to remove completely the lunate arthroscopically. And if you have any doubt about the stability of the scaphoid, then you just do dorsally, doing some kind of DIC application that you would do for any kind of scapholunate instability. And that way you can prevent a little bit the scaphoid to flex and to destabilize. The only thing you cannot really prevent by doing this is the ulnar translocation that you can have also sometimes by removing the lunate, by being a little bit aggressive to the radiocarpal ligament, especially volarly. I don't remember how it was on the beginning X-ray, but if there is already a slight or moderate ulnar translocation before the surgery, that might be the only thing to think about by doing an isolated lunate removal, because it could worsen it. That's it.
Okay, great. Francesca, just a short and the last comment because we need to go on.
Yeah, no, it depends on the ligament stage. As Lorenzo said, I think you can do an isolated lunarectomy if the radial column is not affected. But me, for example, I made the mistake of doing a lunarectomy in a young patient that had almost stage 4, and it was a complete failure. And me personally, in this patient, I would even have offered her a Motec prosthesis.
Okay, thank you, Francesca. Juan, can you go on with the treatment you did?
Yes. Okay, so here's a short video. I will pause in between to explain a bit what happened. So this is patient's hand before operation. So we did so we did the PN AN neurectomy first. Followed by that, we harvest the bone graft from the distal radius. This one is not very working well. Okay, let me see. Okay, so we inserted the guide wires into the scaphoid first, but we did not pass through the SC joint yet. Then here is the arthroscopic part. Started with exploration and debridement first. And see, there's also TFCC injury for this patient. Then at this view, you can see the lunate bone is relatively hard, but in the mid-carpal joint, you can see free bodies. And there's another view to capture. Yes, why this keep moving? Sorry. Yeah, you can see the fragmentation of the lunate under the scope, which is very clear. Okay, then is to using a burr slowly remove the lunate. It takes some patience to do it. Okay. Then after that is burning the radio, the acid joint. So from the skate foil, then later the capitate. Then we push the bone graft into the joint space. We normally just use this needle sheath, which is quite handy and cheap. So pack the bone graft into the joint space, pass through the guide wire, then screw it. Which is strong and stable. Okay. So here are some additional photos to see the intro-op process. This is the bone graft. We pass the bone graft from the needle sheath. Then some intro-op IIs from bone graft harvesting, the pre-inserted K-wires. Then this is what we use using the II to identify the bone we're taking off. And step by step, we need to use II to confirm if we have cleared everything, because sometimes the view in arthritic joint can be quite limited. Then before the fusion, we inserted a joint stick to correct the flexion of the scaphoid before completely fuse the acid joint. Okay, and you can see here after the fusion, the radial scaphoid space seems to be increased. However, this is correctable and reducible. Okay, then this is the first X-ray after the surgery. At this point in time, you can see the scaphoid posture has corrected. And the bone contact is quite significant. It's quite good. Okay, here are some post-op outcome photos and videos. So for the first few weeks, we're putting patient in a brace just to immobilize the wrist, but we allow and encourage patient to have finger movements. This is POD 12, the wound all healed. Patient has been quite cooperative with the finger range of motion exercise. And this is about 6 weeks later. Patient's pain has much improved. She's happy at this moment. The wrist range of motion has also regained. Okay, then there's a little bit side back, which is after about 3 months. After the surgery, patient went overseas to travel, but she carried the big luggage with her right hand, which is an operated hand. Then after that, she experienced a recurrent of pain and reduce of grip strength afterwards. In the clinic, we see that there is mainly tenderness around the radial styloid, ulnar styloid, and pisiform region. And at this moment, just now, the right hand grip strength has decreased from 14 to 2 only at this point of time. So we have discussed with this patient about a surgical options at this moment, since there's a recurrence of pain. If you want to proceed with the radial styloidectomy, keep in view something to address the pain in the other part of the carpus, but patient at this moment, she decided to wait a bit, putting on a splint and rest for a while and see what happens. And this is taking after 10 months. The pain actually improves a lot, and the strength also improves a lot. At this moment of time, patient's pain score is 0 at rest, and the mild pain during her working and house chore activities. The grip strength came back to 13, 14 with a quick dash score about 2.3. So at this moment of time, patient is very functional, very happy, and able to carry on with her old job. Yeah, here's the video.
Does not seem to have sound, but essentially she
Yeah, show
seems to be
off.
she seems to be quite happy with the wrist. But the X-ray, you can see that is not so great. You can see that there is some ulnar translocation. The radial scaphoid joint space has reduced quite significantly. That's why when she had the pain back at about 3 months, I was very worried. I think maybe because, like maybe I could have done a DIC placation to sort of stabilize the scaphoid, the proximal carpal row. So that's why there was a decision on whether to do some form of a completion removal of the pisiform and maybe tricutrum or some form of dermal allo interposition. So we've been observing her, and so far the last time I saw her was just last month. So far, so good. So yeah, this is the case that I have.
Okay, thank you very much. Thank you very much, Wang. I know that there are many persons with the hand
I think Wang,
rising,
sorry,
but
Wang, sorry, Gustavo, Wang,
yeah.
you finished your case, your presentation?
Yes.
Okay.
The case part is done. It's just for the discussion.
Okay. Gustavo, yeah.
No, yes. The thing is that it's a very interesting case. So I want to thank Wang and C to bring this case to us. So, but before end the case, because we have to move to the next case in order of the time, in honor of the time. I want to hear, if it's possible, the master, and to know the opinion from Andrew Chin. Professor, are you there?
Andrew. Yes. Yep.
Andrew,
Hello, Andrew. How are you doing?
Just to
I'm doing
close
fine,
the
thank you.
case, we think it's very
Yep.
interesting to hear about your opinion, because you're of course you're the master in this symposium.
No, I'm not a master. Thank you. You people are so good in giving your opinions, and they're also valuable, and indeed it's very enriching and educational for me as well. I just want to point out the fact that this we are happy that this patient had a good outcome, but certainly there are many ways we can deal with it. And I just want to I'm not too sure, because based on the last X-ray, you can see there's actually an ulnar translocation. Right, the whole entire carpus has shifted ulnarly. That's why patient at first also had some pain over the ulnar styloid, because I think it's probably from the ulnar styloid impingement as well, because it's the whole entire carpus. If you look at the latest X-ray, has actually shifted. But thankfully, I mean, the patient did get better over the subsequent visits, and we're just hoping, eventually she may definitely require something a little bit more definitive in the form of a wrist arthrodesis or something, a total wrist arthrodesis. But I think that would be probably at a later stage. But certainly, I did ask a question about artificial lunate implants. I'm sure some of you may have experience doing that, and whether that could also be a solution to help this patient as an alternative management strategy. But certainly, I think this lunarectomy and scaphocapital fusion has actually proven itself based on the studies that have been published. And certainly, it helps to prolong the life of the patient who are active, giving the patient some range of motion, which I think that's why Zirin and Wang Qiao chose this alternative for the patient. And the patient accepted it after a long discussion and consultation. So I think thank you very much. I think the panelists have contributed so much, and we are grateful for your comments and your suggestions. Right. Over to you, Alam.
Thank you, Andrew.
Thank you, Andrew.
Thank you, Andrew.
Wang, can you show the final review?
Okay, so I have dig into the literature a bit. Basically, there's no consensus what is the best way, and everybody reporting their way to be at least efficient, and the patient is improving and happy and becoming functional. So I have some examples. First of all, this is a case of a similar treatment with lunate excision and scaphoid capillary arthrodesis for late-stage Kienbock disease. They reported strength improved, pain improved, functional-wise, patient is quite functional and happy. Then we also have another paper. They shows there are 11 patients with quite long-term follow-ups with similar treatment, lunate excision and scaphoid capillary fusion. Shows improved functional status, improved pain quite significantly from 8 to 1 and range only 0 to 3, which is quite impressive, and quite functional range of motion. We also have seen there are other alternative. For example, this is a paper says they do scaphoid capillary fusion, but they do not excise the lunate, which they also believe that this works for functions for the pain. And we have other alternatives. For example, this case actually they compares the outcome of scaphoid fusion with proximal corpectomy, which probably is another quite popular options in many centers. And what they find is they both works, they both reduce pain, they both improve function, and some difference that may be taken into consideration when you discuss with the patient is that the data seems to show that for the proximal corpectomy cases, they preserve the range of motion of the wrist a bit more, but for the scaphoid capillary fusion patients, their strength, the grip strength seems to be better. So one way is more preferable for the range of motion, the other way is more preferable for the strength. So I think that's some information patient probably should know before they make a decision. And here is another quite interesting treatment I have to say is it's more less invasive and disruptive, which is a just lunate core decompression, which they reported 40 patients in their series. Also improve function, improve pain, and quite functional grip strength and the range of motion. And there is another comparing studies comparing these three different treatment, which are the scaphoid capillary fusion, tendon ball arthroplasty, which I really don't have experience. We didn't do this before. Then is the radial metaphyseal core decompression. According to their paper, is all for the late stage Kienbock disease. And again, all of this treatment seems to be working in terms of pain, in terms of function, in terms of strength and range of motion. And they do have their unique aspect to show that in the tendon ball arthroplasty group, the wrist range of motion is slightly worse. For the stage A patients, all these three treatment seems to have similar outcomes, but in a 3B disease, all these are in my screen. Sorry, I need to remove them. In the 3B disease, there is a little bit difference in functional performance, which the radial decompression group seems to do better than the other treatment. So that's what I have for the little review. None of these are high those like random grouping kind of studies. They are basically retrospective studies, but I think they do review surgeons' experience with different treatment, and it's quite valuable in the literature for us to take considerations.
Thank you, Wang. Thank you very much. Thank you very much. Very nice review. So just 1 minute to close the case. Alfonso, you were raising your hand, and Luciana, I don't know if you want to say the last comment.
Maybe, Wang, you can stop to share your screen to have everyone. Yes, please. Thank you.
Alfonso?
Yep. There was a beautiful question in the audience, which talk about what is our opinion in the ultra translation of the corpus in these cases. So I think in 1 minute we cannot discuss about it, but I think we should think in this beautiful case. Thank you, Juan and Se, that probably we need to add something to stop the ulnar translation of all the corpus, because probably the patient is going well in the very short time, in 1 year or almost 1 year, but what can expect in 5 or 10 years? That's my principal question in this case.
Thank you, Alfonso.
I wanted also to share something that we were always taught that you cannot do lunectomy when there is ulnar translation, and you need to add scaphocapitate effusion. But with this case, we see very good that you don't prevent it with the scapholunate fusion, the scaphocapitate fusion. So I think the answer might be in the capsula and the capsular ligaments, and we need to do something with the extrinsic ligaments to avoid it. And maybe the scaphocapitate fusion is not the answer for ulnar translation. Okay, this is my opinion.
Great, nice. So, okay, Alejandro, 1 second, last comment.
No,
we need to move to the next case. Sorry.
Yeah, sure. Just a question to all the panelists. Do you have any experience using the polycarbonate implant in these cases in particular?
No. Does anybody?
No, I have no.
Okay. Okay, let's move to the next case. Se
and you,
Wang,
Alejandro, do you have
very much.
just Alejandro? If he is asking the question, you have an experience, Alejandro? You?
No, the thing is that I remember that I have an experience with you using it in the necrosis of the scaphoid, and it was great results. Remember that you presented the case like 2 wrist forms ago. That's why I asked the question.
Okay, thank you.
Okay, thank you, Wang. Thank you, Se. Very nice and interesting case.
Thank you.
We will learn a lot from it. So now we need to move to the next case. So I want to introduce you Angel Leon and Fabio Tandioy. They are going to show us the next case. So Angel, if you can share your screen and introduce yourself, please.
Okay, sir. Yeah, I'm going to share. You can see it?
Great, yes.
Perfect.
Hi. Hi. Good morning and good afternoon for someone. I am Angel Leon. First, I would like to thank Alain Arnaud and the International Greece Center for the opportunity to be here to speak today. I'm Angel Leon from Maracaibo, Venezuela. My professor Fabio Tandioy and I will present you a case of radiolunate ligament avulsion repair in distal radius fracture. Hi. Well, the clinical case began with a motorcycle. This patient has a motorcycle accident. He's a 24 years old male, left hand not dominant. He works as a messenger. He's a delivery man. Now we have here the images. We have here the X-ray, the front view and the lateral view. We can see trace of joint fracture with a bolar fragment. We can see
Sorry, Angel. Alam is sharing the question for the audience. If you can answer the
Yes.
question, please. So you
We
can.
have many questions. The first one is, in your opinion, please, for the attendees, in your opinion, which fracture fragments are more critical in this type of distal radius fracture? This is a crucial. And second question we will answer with the panelists, which ligaments could be injured in this type of fracture? It is the basis. And how do we fix this kind of distal radius fracture? And should we reinsert the ligaments if they are injured? So that are the quizzes. Thank you.
Thank you. Please go on, Angel. Sorry.
Okay.
Go on with the CT scan. Great.
Yeah. Now we have here the CT scan. We have the sagittal, the coronal, the transverse side. We can see a central depression. Okay, we can see multiple small fragments in that often do not have the due importance of them. We can see an important ulnar and radial volar fragment that are very small, but have some importance. Now, in your opinion, which is the key fragments of the distal radius fracture?
Okay, this is what we asked to the audience, but I want to hear the opinion from the experts. So, say, last case you were the presenter, and now I want to hear your opinion. What do you think in this case? Which is the key fragment in this distal radius fracture? What do you see in the CT scan?
Well, the volar ulnar fragment where the lunate is sitting on seems to be affected, but it also seemed to be extended towards the volar radial fragment as well. So there's some comminution over there. It looks very unstable, definitely. You can see that the lunate is like sort of almost subluxing volarly as well. So that is something that is of concern.
Great. Carlos Morales, how are you doing, my friend? What do you think in this case? How do you plan your surgery? How are you doing? How or what do you see before planning your surgery in this CT scan?
Yeah, same thing that you say. I think that the main fragment are the ulnar fragment, but also the radial volar fragment are for me the key fragment. Definitely there's some kind of compromise about the radiocarpal stability. And that will be my main concern will be this one, the stability of the radiocarpal joint.
Great. Thank you, Carlos. Alfonso, what do you think?
Hello. There's a very good case, Angel. Thank you so much for sharing. We can see the volar translation of almost the whole carpus, so probably the key fragment is the volar rim. We can see if we think in the attachment of the ligament in the volar area, we can see all the carpus is translated to the anterior area. So probably fixing only the the volar key fragment probably will help us a lot doing everything in this case.
Okay, and in terms to fix this, how do you plan the fixation in this kind of fracture in the surgery? Lorenzo, what do you do for these unstable little volar fragments?
So usually in that type of case, I usually my go-to choice would be a fragment-specific fixation with a hook plate or a buttress plate that could really stabilize the volar fragments to the shaft. And usually, most of the case, it will also treat the ligament problem because usually the ligament is still attached to the bone fragment. So by doing only the fixation, specific fixation, you can treat the whole problem. But if needed, you can also reinforce or retighten the ligament in the same case, of course.
Thank you, Lorenzo. Carlos?
Yes, in the same order of idea, it's a question for everybody and for Alfonso. Alfonso, how important do you think that the ligament aspect is for this, sagittal displacement over the simple bone issue? I mean, if you fix this bone fragment, it's not enough to reestablish this displacement and this is instability?
Well, I think the attachment of the bone is clearly in the radial volar fragment, so probably it's not a problem of ligaments. So it's probably a problem of bone. So the bone has the attachment of the ligament, and then if you have a volar shift of everything in the carpus because the ligament is still attached. So probably if you fix only the bone, I think will be enough. Probably, as Ali says before in the chat, we must do an arthroscopy to see if there's some intra-articular foreign bodies or cartilage or whatever, and also ligament structures damage. But I think if only fixing the bone, probably you go very well.
I want to share again the opinion of Ali Kavid. He thinks that you need to do a fluoroscopic examination in the operation room under anesthesia before and after fixation to see the ligaments.
Great.
I don't think you have to do an examination in the X-ray because if we think in anatomy, the ligament is still attached. That's why the whole carpus goes to the volar area. Probably if you do a pre-operative fluoroscopy, you can see that. But I don't think you have to do it after the surgery.
Great. Thank you, Alfonso. Okay. Anybody wants to say something about this before going to the treatment?
I think, can I add something?
Yes, of course.
The main actor here is the volar ligaments and the volar fragment, but we should not forget the impaction central fragments that are often associated. So we don't only need to bring back the ligaments and the volar fragments in their place, but we also need to take care of the die punch fracture fragments in the middle. It's very important. So for this, arthroscopy is mandatory.
Okay, great. Thank you, Lucian.
Totally.
Alam, what do you think about this? How do you treat these little volar fragments that are very unstable? They have the ligaments, and perhaps with a volar standard plate, you cannot fix them.
Thank you for your question, Gustavo. It's a very difficult and complex case. I recently received a patient that was operated elsewhere. In this, I cannot share the pictures here. We don't have time, but in this the same case, they put a simple volar plate just, and we can see after 1.5 months, the first X-ray was more or less good, and we can see in 1.5 months progressively the volar translocation of all the carpus. If this kind of fracture is not treated exactly with anatomical restoration, very distal anatomical restoration, it will be a disaster after, because an intra-articular osteotomy of this kind of fracture after 1.5 months to 2 months will be a disaster. So we need, in the first place, in this kind of fracture, to treat, to fix only the bone. That's what I do, using fragment-specific plates, or to add some ligament reinsertion. Personally, I do only a bone fixation. In this kind of case, it's enough for me if we restore the anatomy. But we need to restore the anatomy correctly in the first place. A simple volar plate is not enough.
Thank you, Alam. Thank you. See?
But we have some problems with fragment-specific plates. We have also on the market for us the ulnar fragment-specific plates. We don't have any plate for the radial side. Does anyone have a fragment-specific plate for the radial side? I need the opinion of the panelists, because we have this problem. Lorenzo, I don't know which plate you use.
Yes.
Maybe we have the same plates.
No, we have one.
No, we have the new clip one. On the new clip one,
as a volar specific fixation plate.
it is not enough. There is not a hook plate for.
Sorry, because I understand both of you. Alam is saying, Lorenzo, that the specific volar hook plate of new clip is for the ulnar column, for the critical corner, the anterior rim of the lunate facet, but she's asking for the radial column if somebody has
Thank you, Gustavo, for translating what I'm telling.
On the document,
I know Afrex has one.
Because I couldn't find one hook plate for the volar the radial column, and that is a problem.
There is the Acumet plates. You can add a hook wherever you want, like in the distal screws. You can add the hook wherever you want. You can even put 2 hooks if you want.
We don't have it. We don't have them.
You know, there is a technique described by Moore and Denison some years ago, when we didn't have any specific hook plate. They used to like a spring wire. They fixed the little fragments with 2 key wires, and after that they bend the key wires and you can hide the key wires underneath the standard volar locking plate. So in this way, you are making like a hook with the key wires is not the same with the specific volar plate, but it's very useful. I really use it many times, and I always have a very good and nice experience with this.
Please share the case next time, Gustavo. We are interested.
I will show it to you, because it's very easy and cheap way to solve this problem. You introduce 2 key wires, and then you bend the key wires in order to hide these key wires under the plate. So you make hooks wherever you want with the key wire. You need to use a very thin key wire in order to bend the key wire under the plate. Okay, Angel, can you go on with the case? I want to see what you have done.
Yes, sir. Well, we have another question. Do you think any ligament might be injured?
Well, this was when we were talking about.
Well,
Yes, you can go on.
okay. Now we have the distal radius fracture was reduced first by a polar approach, and finally the pressure of the lunate facet was reduced by arthroscopy, and the avulsion of the ligaments was identified at the same time. And we noticed that the avulsion fragments were very small, so that the fix of them were very difficult. Now we do the ligament test by after that the radiolunate ligament avulsion is tested, and the long and the short ligament are evaluated by using a hook. Then, as the first step of the technique in repairing the ligament avulsion is to apply a suture anchor at the ligament footprint through a volar approach, distal to the blade of the distal radius. The second step, we introduce the scope through the 1 to 2 portal, allowing the visualization of the catheter pass through the short and long radiolunate ligament. We use the 14G catheter that pass through the 3 to 4 portal to assist the ligament repair. Now we do as the third step of the technique, we introduce the catheter pass through the short radiolunate ligament. At this point, the catheter was loaded with one strand of the suture of the anchor. It is very important to ensure that the suture forms a loop at the end, so the entire strand does not pass through. And also, you have to be careful with the median nerve when the catheter passes through the volar side. Now, when the catheter is loaded with a suture, it will draw slightly without leaving the joint, and then reintroduce, this time passing through the long radiolunate ligament, guiding the catheter. We use a needle to avoid any injuries, guiding the catheter. Now it's coming the needle to guide the 14G catheter. Now, at the fifth step, when the catheter passes through the long radiolunate ligament, the loop of the suture becomes visible at the volar side, and the entire suture is then retrieved. And the light suture is then retrieved from the volar side, as we do as we show in the video. Then after that step, we release the traction, and the suture is tight, and the ligaments are then reinserted at the volar fracture. Now, at the post-operative of our patient, we use a immobilization in a spleen for 3 weeks. Therapy is started after removing the spleen, and we follow up the case using by CT scan. We have here the follow-up the CT scan, and we can observe a proper reduction of the volar fracture, subchondral placement of the plate, and good position of the anchor. We can see how we can reduce the small and tiny fracture. As a conclusion, we can say that arthroscopy allows to identify and repair avulsion of volar ligaments. And we have a technique, we do a technique that is easy and reproducible. And the time of immobilization is short, only 3 weeks.
Thank you, Angel. Thank you very much. Very nice and interesting technique in order to fix these ligaments and volar little fragment. Fabio, I want to ask you something. Do you, in these cases, do you place the volar locking plate a little bit distally in order to hold, to fix more these little fragments, or you place it just proximal to the watershed line?
Sorry, just Angel, please, could you stop sharing your screen so we can have everyone for the discussion, please?
Sorry.
In this case, the fracture was very near to the joint. I put very near the plate, very distally of the distal radius fracture. Obviously, I recommend the patient. Here in my clinic, it's easy to follow my patient and recommend if they present some pain in the thumb finger when they flex the finger, please shears me, because in this case I need to remove the plates. But if you see the CT scan, the plate was very distal, and don't follow the rules about the water lines.
We have some questions from the audience. So Mariano Obeid asks if the suture is an inside knot.
The suture is
an inside knot. It's from the inside.
The suture is put the suture anchor put distal to the plate, and Gelco introduced for 3/4 pass through the ligament, and when the
so
Gelco
it's an outside in technique, right?
It's out,
not
yes.
on inside. Okay.
Yes.
And Muhammad Magdi is asking if you open the patient volarly and apply the plate, why not to apply the anchor in the same time? But I think that you apply the anchor in the same time, right?
Yes, in the same.
Okay. And they ask, why didn't you use a fragment-specific plate, Fabio? Please answer them.
In my case, at that moment, because this case was in 2020, was difficult to get here in Colombia, a specific plate for the volar side.
Okay, so I think this is important that some of us work in a fortunate place that we have everything, but it's also very interesting to see people that work in places that they don't have all the plates, And sometimes they have much more clever solutions than we have. So this is why these webinars are so amazing, because we share opinions from Asia, from South Africa, from South America, from Europe, and we grow like this. It's very important. Not everybody has the same plates, and even us in Europe, sometimes we have a case and we don't have in the magazine, in the operation room, the right plate. But it doesn't mean we cannot treat it, So thank you, Fabio. Katerina Kasabinova is asking, why do we need arthroscopy to pass the wires of the anchor? Can you explain this? Why do you need arthroscopy to pass the wires of the anchor inside the ligaments? Because she thinks that if you opened, you already see the ligaments. So
yes, but in this case, it's more easy to see from into the joint with the scope, because I pass through the real portion of the ligament with the one gelco in the more ulnar side, and then in the more radial side, the amount of the ligament is more easy to see what kind of ligaments are reattachment.
Okay,
This is my
so it's for precision.
yes.
Kantan is asking, where do you put exactly the anchor?
Very distal, but obviously need to take care with the position of the suture anchor, because if put bad the suture anchor, I put into the joint the suture anchor. But my plate in the CT scan was very distal, and put more distal the suture anchor.
Okay, so as you see, those fracture cases are very interesting, because we have a lot of questions. And okay, you have another one. Ain Edwin is asking if somebody will add a dorsal bridging plate to secure the fixation and the wrist. I don't know. No, me neither. Some of you, I don't know.
No.
No.
But
it
I
was
think that
it was the idea of two people in the quiz. We have two people that choose the bridge plate fixation. We need to keep in mind.
I think if you cannot do arthroscopy, or you're not very, very sure, if you put a dorsal spanning plate, at least you're safe that it will not,
But the main problem with a dorsal plate is that, as Lucian said, you cannot control the central fragments. So probably if you don't have arthroscopy, the dorsal bridge plate cannot add nothing at all.
Yes. Jerine, I don't know. Gustavo, you want to manage? I see Jerine is asking a question. I'm finished with
very well, my
with the
friend.
form.
I want to give I want to hear the opinion of Se, that is raising the hand. Se?
Yes. I wanted to first congratulate Angel and Fabio for like a good case. It's actually quite a very, very smart way on fixing the distal radius fracture, as well as repairing the volar carpal ligaments. I think it's a very important case, but personally, how I would approach it, there's this plate that I always use. I'm not sure whether you guys have it. It's a Megatis plate, which is this volar rim plate. Oh gosh, can't see, huh? Volar rim
we
plate.
can see.
It actually has these two little small prongs that actually helps to catch the volar ulnar rim, which I think that is actually really, really useful. And the plate can actually place very, very distal, and it can catch most of the fragment. And from there, sometimes I do have cases where the volar carpal ligaments look avulsed from the outside. But a lot of times I do put arthroscopy as well, especially if the distal radius is actually there's intra-articular fragment that's displaced. So I always put the arthroscopy, but I've never actually repaired it through the arthroscope. But I think one way we can do is also to put a suture through one of the holes in the screw. And then with that suture, you can actually bite and catch the volar ulnar ligaments, and then suture it from the volar side rather than doing it from the arthroscopy, if arthroscopy is quite challenging for some people. I think this is also a very good option for you to repair the volar ulnar ligaments.
Yes, exactly. Another very nice option. Thank you very much, Se. Okay, thank you very much to Angel and to Fabio. I think we are on time, but I don't know if anybody wants to say something.
Maybe we don't have any more questions, Lucian.
We have one more question.
One more question.
About, do you do also a mid-carpal diagnostics for the scapholunate ligaments?
In
Do you
this
think
case,
it's necessary for this kind of fractures?
yes, I believe it's important to check, no? Because the force of the strength of the fracture was high. We need to check the mid-carpal. It's easy. I don't spend a lot of time. And if I see some injuries, it's easy to repair, obviously, by arthroscopy too. But in this case, I check. I don't have anything in the mid-carpal and only fix the fracture and repair the radio volar ulnar ligament.
Thank you, Fabio. Thank you, Fabio. I think we are spending a very good moment with all these cases, but we need to close. There will be many other webinars. Thank you, Gustavo, Lucian, for helping me, Lorenzo, all the panelists. Thank you to all the speakers. The cases are very great today. Of course, thank you to the participants for staying until the end of the session. So we will have a certificate of attendance for the participants if you joined for more than 75% of the webinar. And you will also get the full results of the quizzes by email today. Next webinar is in 1 month. We are looking forward to seeing you again. And I wish you a nice day. Thank you, everyone. Bye-bye. Have a nice day.
Bye-bye.
Thank
Bye.
you.
Thank you.
Thank you.
Have a good weekend.
Bye-bye.
Bye.